الرحمن الرحيم. يا شباب شباب اللي هناك يا بالاكسر اللي جنبك. طيب خلاص خلونا نبدأ يا جماعة. طيب خلاص تمام. أقول
الصوت واضح عندك دكتورة؟ بروف صوت شغال؟
يلا اوكي.
ما نسمع الصوت.
البرزنتيشن القادم
ما في صوت ما في صوت.
شغال يا دكتور شغال. بسم الله الرحمن الرحيم، والصلاة والسلام على سيد المرسلين سيدنا محمد وعلى آله وأصحابه أجمعين. بنواصل جلسة اليوم المحاضرة القادمة أو البرزنتيشن Teaching Patient Safety in الأزهر Medical School 5 years experience. It will be presented by Professor Mustafa Abdul Nasser. A brief CV will be
Professor Mustafa Abdul Nasser is a professor of microbiology and immunology and infection control at the Faculty of Medicine of Al-Azhar University, Cairo, Egypt. And also he is a counselor for Quality Assurance Unit of Education in the same institution. نرحب بالبروفيسور عبد الناصر، وهو الآن القاعة للبروفيسور عبد الناصر. He will start his presentation.
بسم الله الرحمن الرحيم. الإخوة الأعزاء باليمن وجميع الدول العربية، my dear. بسم الله الرحمن الرحيم. الإخوة الأعزاء باليمن وجميع الدول العربية، my dear guests in this conference. The reform of medical education towards safe health care in مكلا في جامعة العرب. My presentation today is teaching patient safety in Al-Azhar University Medical School, 5 years experience. Patient safety is a healthcare discipline that emerged with the evolving complexity of healthcare system to prevent and reduce risks, errors, and harms that occur in patients during the provision of health care. Actually, in 1999, the Institute of Medicine made a report that highlighted safety problems and paved the way for reducing medical errors. Actually, also in 2011, the WHO issued the multi-professional patient safety curriculum to assist teaching patient safety in universities and schools in the fields of medicine, dentistry, midwifery, nursing, and pharmacy. It also supports the ongoing training of healthcare professionals. And this is the multi-profession curriculum, which is issued in November 2011 in different languages used in the WHO, and the Arab language is within this language. The objective of this lecture is to highlight the implementation challenges and suggest solutions in teaching patients safety. Actually, in Al-Azhar University, we adopted the teaching patient safety maybe 10 years back to this date. and in 2017, during our annual conference of Al-Azhar University Medical School, a call for teaching patient safety was presented, and in 2018, it was embedded in the new integrated medical program approved by the Egyptian government as one of the modules of a group of professionalism. At that date, actually in 2018, the medical curriculum in our faculties and in all medical schools in Egypt was changed from teaching medicine 6 years plus 1 year for training years to be 5 years teaching and 2 years training. And many changes have been made in the curriculum. Within this was teaching professionalism, and the most important topics was patient safety as a module taught in phase 1 of the second year in semester 4 since the academic year 2019 to 2020 as 1 credit hour, 15 hours in the first semester of the second year. And this is the topics issued by WHO, and we stick to these topics, which is these 11 topics. I'm going to speak in brief about these topics and its aim for the sake of time. The first topic was what is patient safety, its concepts and perspectives, and the objectives of this was to understand the discipline of patient safety and its role in minimizing the incidence and impact of adverse events and maximizing the recovery from them. And this is a holistic introduction for patient safety. And the second topic is about what is human factors and why it is important to patient safety. And the objective of this is to describe the meaning of the term human factors and ergonomics, the relation between human and articles and devices, and how to accept this, how to modify this for that, or modify that for this. This explain also the meaning of the term human factors, and explain the relation between human factors and patient safety. Also to apply human factor thinking to work environment and the reliance on memory, and how to make a checklist so as to not always rely on memory. And the third topic is to understand how system thinking can improve healthcare and to minimize patient adverse events, and to describe the Swiss cheese model, which says that there is some holes in every system, in hospital, in education, or in any institution, and how to overcome these holes to improve the system, and to explain why to explain the meaning of the term system and its complexity, and also to modify and simplify process, make things visible, and to explain the system approach to patient safety and why it is superior on the traditional approach. And in this, we try to work all as a team, as we will see here, to understand the importance of the team in healthcare, and to know how to be effective team player, and to recognize you. This is for student, to recognize the role of the student in the team during the teaching, during the training in the hospital, and to work effectively in groups, and to maintain responsibility toward this work, Also to show respect for each patient differences, religions, cultural beliefs, and individual needs. And the fifth topic is to understand and learning from errors. Understand the nature of the errors and how how healthcare can learn from errors to improve patient safety. Also to enumerate the violation from system, and to enumerate how to report any errors during health care, and to define patient safety culture, how this culture is safe for working of the health care, the culture of no blaming, and to assess the barriers for implementing safety culture. Also understanding and managing clinical risk when there is a risk, how to manage this risk. We have also a module about risk management, but we teach risk management here as a lecture. To know the activities and used for gathering information about risk, and to understand the personal accountability for managing clinical risk. Here we divide or classify risk to minor, moderate, major, and high risk, and to recognize the situation and how to deal with each type, accept or cancel or manage or etc. Also to recognize the situation associated with increased risk of errors, and to recognize the value of incident reporting and distinguish the role of patient safety culture in minimizing the risk. The quality in improvement is also a topic which is very important in understanding patient safety. So we give a brief about the basic concepts of quality improvement, and to introduce the methods and the tools of improving healthcare, and to know a range of quality activities, and we teach also the plan, do, study, act based cycle developed by Deming, and to prepare safety tools as root cause analysis to analyze any accident or any fault, and why this happened, by the 5 why, until we come to the acceptable solution, the cause and effect by using the cause and effect diagram. Also, there is a topic about engaging with patient and carer, how to engage the patient in decision making, understand the ways in which patients and carers can be a partner in health care to prevent harm and learning and healing from adverse events, and also to understand the basic communication techniques between patient and the health care team, and to learn from informed consent, and to recognize the basis of open disclosure, to say to patient and to inform him about everything about his disease and management, and also to minimize infection through improving infection control, which is one of the most important topics in patient safety, to describe and minimize the risks of contamination, and to recognize the effects of infection control measure, also to apply standard precaution and list the main types of hand hygiene, which is very important, and there is a hand hygiene day every year, celebration 5 May, to stress on applying hand hygiene guidelines as said by WHO, and using personal protective equipment. And one of the most important topics is patient safety and invasive procedure to list the main types of adverse events associated with surgical and invasive procedures as catheter-associated infection, line-associated vascular line-associated infection, and ventilator-associated pneumonia, to apply the verification process to eliminate wrong patient, wrong site, and wrong procedure before surgery, and also to identify safe surgery checklist by what is called time out, which is a check before surgery to prevent the risk and the errors which may happen to during surgery. One of the most important, and was the last topic before modification of this curriculum, which was introduction to medication safety, to describe the scale of medication errors and identify high risk medication, recognize common hazardous situation, outline common sources and factors that contribute to medication errors, and identify the steps of using the medication sources of errors, and to define doctors' responsibility when prescribing and administering medication, and to describe the benefits of a multidisciplinary approach of medication safety, because medication is a responsibility of the doctor, pharmacy, and nurse, and also the patient when engaging him also to the in his management plan to distinguish learning the lessons from medication error and near miss, and to recognize and be familiar with the medication you prescribe. This is for the patient, and at the end to describe how to make medication safe for patient. The last topics which was recently added in this year is the role of artificial intelligence in patient safety, and this is here to stress on monitoring patient, using artificial intelligence to monitoring patient, supporting the populations, health management, automating lab tasks, surgical, guiding surgical care, recording digital clinical notes, producing or predicting health care trajectories as outbreaks and also and emerging disease and emerging, and recommending the treatment, optimizing operational processes. It is our objectives is to define artificial intelligence, give them a brief idea about artificial intelligence, and describe its basic principles and how to apply artificial intelligence in healthcare, as we said in last slide, and discuss its benefits and describe the risks and how to contain this challenge. Now, the educational methods used in our curriculum is a combination of traditional lecture, interactive and didactic sessions, which is firstly it was face-to-face, and then during Corona outbreaks it becomes online, and then it becomes hybrid partially. Some lectures are online and some are face-to-face. Also, we use small group discussions and role models and case studies and some online activities. Assessment is in the form of MCQs and short essay questions and some OSB or structured practical exam. Now, what is the challenges and what are the suggested solutions for teaching patient safety? Being 1 credit hour, the time is not enough, and there is a stress on only giving theoretical activities or theoretical knowledge. We try as much as we can to include some cases, to give some examples, but this still time is not enough. So we hope to upgrade this to 2 credit hours to include problem-based classes and like other modules and some practical sessions, and to make or arrange to site visits in hospitals to see how infection happen and how to manage, how to manage any medication errors, what about the incident report, how to write, etc. One of the most important issue is that we give students a chance to make a survey about the benefit of patient safety and how to improve patient safety as an integrative the topics of patient safety by giving by prepare true and false questions and some MCQs about the topics of patient safety as we see here, and this work will be presented in one of the international conference. And the conclusion come from this is that fostering a patient safety culture and implementing comprehensive training for medical students are expected to play a pivotal role in safe healthcare practice. In conclusion, teaching patient safety provides future doctor with knowledge, skills, and attitudes about how to work and support safe workplaces. Implementing artificial intelligence in patient safety curriculum helps in maintaining the sustainability of safe healthcare. And this is the reference, and thank you, and hope you a good conference in this in our dear part of the Arab world, the Republic of Yemen. Thank you very much.
برا ولا هنا؟
أنا بس.
والله. اوكي.
دكتور أنيسة بتصحي لنا اللي ناموا بعد الغداء.
لا صاحيين شوفهم كلهم. طيب next presentation is for Dr. Wahib Al-Qubati, Emerging Perspectives in Medical Education. تفضل دكتور.
وهيب القباطي he is a professor from Sana'a University as a consultant general surgeon and colorectal surgeon, and also he is a trainer in the postgraduate for the Arab board and Yemeni board, and he also one of the teaching staff of 21st September University. نرحب بالدكتور وهيب القباطي for to present his presentation.
السلام عليكم ورحمة الله وبركاته. شكرا جزيلا لاستضافتي لديكم لمؤتمر الثالث لكلية الطب والعلوم الصحية في جامعة العرب عن التعليم الطبي. My lecture is about emerging perspectives in medical education, in-depth analysis and current trends. My name is Associate Professor Dr. Wahib Al-Qubati. We know that the overview of the evolving landscape of medical education, importance of diverse student-centered teaching methods, shift from traditional to innovative learning approaches. We know that in traditional lectures, we have strategical role of lecture in medical education for centuries. It has some strength, structured delivery of information, time-bound setting, direct interaction, immediate feedback and clarification from instructors, consistency, standardized delivery of content to all students. It has limitation for passive learning, limited engagement, one size fits all, does not accommodate different learning styles with limited flexibility. Now we are talking about blended learning models, has strengths for flexibility, active engagements, immediate feedback with some limitation like requires for self-motivation. Students need to manage their time effectively, technology dependence, which relies on access to digital devices and internet, potential for inconsistency, varying length of interactions and contents quality. We know the purpose of a lecture to be lovely, educative, creative, thought, understandable, relevant, enjoyable. Enhancing traditional lectures by techniques to improve engagement, like interactive elements and multimedia, or flipped classroom approach, reinforcing learning. Enhancing traditional section, also we have another mechanism by flipping the classroom, which provide pre-class تحضير قبل المحاضرة, such as videos, readings, and quizzes to allow students to come prepared. Also another mechanism by small group sessions. Definition is important for learning involving students working together to discuss analyzing specific topics, encouraging active participation, collaboration, and deeper understanding. Active learning principles, which is critical to encourage students to think critically, to analyze and to justify these decisions. Communication, to emphasize effective communication as students present and discuss findings. Small type of activity, it is a debate type, which facilitated a debate different surgical techniques or treatment options. Another one activity is also problem solving by using exercises related to intraoperative complications or surgical decision making. Also example, per se, organize small group discussions where the student discuss different types of abdominal incisions. For example, midline incision indications, transverse incision, finisteal incision, and their specific indications. Each group could present their finding and discuss the pros and cons of each approach. Active learning principles with critical thinking and communication. Example, assign as a case where a patient presents with acute appendicitis. Students might discuss the diagnostic steps, potential complications, and surgical options for this patient. This encourages the students to have critical thinking and communication as they justify their choices and communicate their plans to group. BBL, which is centered on the student, and it is a problem-first approach, centered around the student solving real-world problems, making learning more relevant and engaging. OSCE, or Objective Structural Clinical Examination, they are essential assessment tool in medical education. Evaluation of students' clinical skills, including procedures, communication skills, decision-making, and it consists of multiple time stations, typically 8 to 12, lasting 5 to 10 minutes each, where the students are assessed on a specific patient care task. These stations cover scenarios like history taking, physical examination, procedure skills, patient communication, with using standardized patients for consistency. The key components of OSCE is a station, standardized patients, and checklist and scoring by the examiner. Integrated by creating a rich learning environment by incorporating a three-dimensional models, virtual discussions and surgical stimulations. For example, students can be using a virtual stimulator to practice laparoscopic collecting, or receiving a real-time feedback to improve their skills. This approach enhances the connection between theoretical knowledge and practical experience. Recent development in electronic learning and digital education tools, either augmented reality or virtual reality. We have also another model for developing medical education is reflection in medical education. Role in reflection in deep learning and professional development with tools like journals, portfolios, debriefing sessions. A lot of studies show the impact of reflective practice in medical training. Its role to help the student and professionals even for critically analyze their experiences, leading to deeper understanding and long-term retention of knowledge. Reflection, it promotes continuous personal and professional growth by encouraging individuals to evaluate their strengths and areas for improvement. By using journals, portfolios, debriefing sessions, writing the journal allows the learner to document, analyze their experience and thought. Portfolios collect evidence of learning, such as writing reflection and case studies and other materials to showcase progress over the time. Also, debriefing sessions, they are guided discussions after clinical experience or stimulation to participate and to have to improve their future. Stimulation-based stimulation, it is very important, and we know that it is the idea of new technology now. Important stimulation in bridging the theory and the practice. And we have so many types of stimulation already in medical education. Mannequin-based learning or education, virtual reality, and scenario-based education. Recent advances in stimulation technology even better for medical education nowadays. Let's take first about the importance of stimulation in bridging the theory and practice. For example, in surgical education, setting for stimulation can be used to teach the student the principle of laparoscopic surgery. We have a stimulator might allow the students to practice the basic movements required for the laparoscopic procedure, controlling the instruments, how to navigate. It's called the hands-on practice, and very important to gain the knowledge later on for practical skills needed in operating room later on in their real surgical life training. Also, stimulation-based education, types of stimulation, as we said, mannequin-based or virtual reality scenario-based. Mannequin students might use a high fidelity of mannequin, طبعا mannequin باللغة العربية معناته العارضة, to practice emergency procedures such as placing chest tube or patient on pneumothorax, how to do chest tube intubation. And the mannequin provides a realistic response to the procedure, allowing the students to develop their technical skills in controlled environment. Virtual reality, by using stimulation to immerse students in virtual operating theater, and can provide the real-time feedback on their performance and their techniques. Another also one, scenario-based example, might also present a case where a patient developed post-operative complication. Per se, anastomotic technique. They would need to work through the steps, how to diagnose this such complication, how to deal with such complication as if they are in a realistic setting. Stimulation-based education, we have a recent advancement in a stimulation technology, and a lot of platforms in the internet helps you to have this type, like LabSim, Flex, Virtual Reality, Lab Mentor, Small, our Simple Box. All of these recent advances will have also the haptic feedback technology, as if you are doing the operation. It's mimic tactile sensation of real surgery. Per se, students participating in suturing on a stimulator can now feel the resistance of the tissue and the tension on the suture, as if they are doing innovation, as they are a realistic and effective training experience. So advancement in artificial intelligence, allowing the stimulators to adapt the learner skills also. And it provides personalized challenges and guidance for each student practicing this type of technology. Here also the last one, which evidence-based medicine. As everyone say now, evidence-based medicine, and to have to write a research on internet or for a journal or an article, and you be a researcher, you need two things. You need a brain and laptop, computer وعقل, just, and everything is available on net. Core principle of evidence-based medicine is integration of clinical expertise with research evidence. It's very important in modern medical practice and education. And it is the current trends now. Anyone will say, Professor Ahmed Badib, anyone will talk about guidelines, and it is of evidence-based medicine. It is a core problem, principles of evidence-based problem to integrate this clinical expertise and research evidence in a surgical education course. It is very important to be implemented like this. They would learn to critically to have either this problem, per se appendicitis, diverticulitis, surgical or non-surgical. What's the evidence here? What's with, what's against implementation of surgical excision of appendix, and other one will say it is a matter of medical treatment. Tools, and we have to train about how to use the platforms in the net, like PubMed, Cochrane Library, to quickly find and apply the latest research during their clinical rotation. Very important. And to apply high quality evidence in their clinical practice. So summary of key points. We are now moving from traditional lectures to more active student-centered learning in modern surgical education. This is a significant shift towards active student-centered learning approaches by three things: self-directed learning, stimulation-based education, evidence-based medicine. Let's say about self-directed learning. It is allowed the students to independently master surgical techniques like suturing by assisting various education materials at their own pace, fostering independent learning and self-assessment. Stimulation-based education is further bridge the gap between theoretical knowledge and practical skill by offering realistic, risk-free environment without risk, where the student can practice procedures like laparoscopic surgery, mannequin-based and virtually reality scenario stimulation, for instance, provide hands-on experience and a real-time feedback crucial for developing technical proficiency. Lastly, for this, evidence-based medicine, which is brain and computer. These methods empower the students to take control of their learning and setting goals, selecting appropriate resources, engaging in reflective practices. Also integrate the clinical expertise and latest research evidence, enabling the students to make informed, evidence-based decisions in surgical practice, per se, choosing the best treatment approach for appendicitis. Conclusion. Future trends is integration of artificial intelligence to be personalized learning pathway for every student. Advancement in stimulation technology by incorporation of haptic feedback, tactile sensation. Artificial intelligence are making it possible now to stimulate a tactile sensation for real surgeries, providing students with an even more realistic training experience. Thank you very much.
شكرا للدكتور وهيب القباطي على هذه المحاضرة اللي هي أساسا تتعلق ب براكتيكال أو سكيلز، معظمها على سكيلز. فشكرا جزيلا. نبدأ بال next lecture.
The next lecture will be presented by Dr. Dina Muhammad Naguib. It is about peer teaching and its role in the development of medical students and medical profession. Please, Dr. Dina.
Professor Dina is a professor for medical education from University of Swiss Canal, Swiss University, and she is focusing on electronic learning and active learning. Now will be with the lecture or the presentation of Professor Dina. Ahmed.
السلام عليكم، أهلا بحضراتكم. في البداية حابة أعبر عن سعادتي وإن أنا بشارك في المؤتمر الخاص بالتعليم الطبي في جامعة العرب باليمن. وطبعا كل الشكر للجنة المنظمة على المجهود المبذول لقيام المؤتمر. هنتكلم we will talk about peer assisted learning. I am Dr. Dina Muhammad Naguib, Associate Professor of Forensic Medicine and Toxicology, Diploma of Health Professional Education from Suez Canal University, and Forensic Medicine Fellowship IBCT Associate Trainer. Objectives: definition of peer assisted learning, categories and terminology of peer assisted learning, peer-assisted learning implementation and strategies, benefits of peer-assisted learning and its role in student development, and lastly, challenges of peer-assisted learning implementation. And as Robert Henlin said, when one teaches, two learn. Peer teaching or peer-assisted learning has been implemented in undergraduate education since 1990, but the popularity of peer-assisted learning activities within the medical education increased since 2000. Teaching is not only an activity, it is an essential skill for future doctors, as teaching a student and the patient is an important part of doctors' activities, and hence the importance of peer-assisted teaching. So let us think about what is peer teaching or peer-assisted learning. Peer teaching or peer-assisted learning is an established teaching and learning method in medical education worldwide. It encompasses people from similar social grouping who are not professional teachers, helping each others to learn and learning themselves by teaching. In peer-assisted learning, there are two parts: the tutor, the student who are assisting their student peers with their learning, and the tutee, the student being assisted in their learning by the student peer tutor. What about the categories of peer-assisted learning? There are three dimensions in practice into which peer teaching can be classified. First, the distance between a tutor and the tutee, group of students taught, and the formality of teaching. Considering the distance between a student and the peer teacher, there are two types: peer teaching, in which a tutor can be equal or at the same level of the tutee. This is called peer teaching. And the near peer teaching, when there is difference of levels and the peer teaching is from an advanced level of training. Considering the group size of a student taught, the group size can vary from one-to-one peer teaching or small group setting or large group setting. Considering the formality of teaching, there are two types: informal peer-assisted learning, in which the student could work together informally by assisting each other in preparation for assessment or explaining difficult concepts for better understanding. And formal peer-assisted learning, in which the student could be required to replace the teachers in an elective or obligatory part of the educational program. Considering three types together, or three categories together, we can have a terminology in peer-assisted learning, like if the distance is low and the group size is low and the formality is low, like students working together to prepare for a test, this is called peer-assisted learning. But if the distance is high and the group size is low and the formality is low, this is called near-peer tutoring or near-peer mentoring, and so on. Implementation and strategies. Peer-assisted learning can be done or can be performed in many levels. It can be has been established in preclinical medicine, particularly in anatomy, physiology, and problem-based learning, or clinical medicine. And this method is applied for training of clinical skills like communication skills, physical examination, different technical procedures, and resuscitation skills. Training and preparation of peer-assisted learning activities. Training and preparation of peer-assisted learning activities is a necessity. So we should train our tutors on many different skills. We should train them on tutor rules like creation of learning resources, small group teaching, formative assessment, provision of feedback, and some areas of difficulty like clarification of the tutor assessor rule, marketing criteria, and discomfort around teaching or tutoring, and the training on some frameworks that may assist them in teaching, like Pattern 4 Steps approach to teach a clinical skills. This is Pattern 4 Steps approach. Many peer-assisted learning activities were published in the literature as senior student as simulated patient in practice of OSCE, senior student as examiners of their junior peers in practice of OSCE, and senior student as peer tutors in the clinical setting. Benefits of peer-assisted learning. It can benefit both tutor and tutee. Regarding benefits to the tutor, peer-assisted learning has beneficial effect of the act of teaching on gaining of knowledge. We know that the learning pyramids the most skill or the most act that can retain information for the student is to teach others. It can retain up to 90% of information. The second benefit to the tutor is social, emotional, and motivational benefit that can satisfy many levels of Maslow pyramid. Maslow pyramid, 8 levels, by its 8 levels, peer-assisted learning can satisfy many levels, from belonging and love, esteem, cognitive, aesthetic, self-actualization, and transcendence, because the relation between a tutor and the tutee can satisfy all these levels. Studies evaluated the reasons to be a tutor. Many studies in the literature studied the reasons to be a tutor among students. many reasons are published, like learning to teach and speak in public, practice their skills, enjoy the act of teaching, help others, had good experience with peer teaching while they were a student, to learn from other peer teachers, and lastly, it offers career opportunities. What about the benefits to the tuti? More effective learning due to two theories, cognitive congruence and social congruence. In cognitive congruence, the student knows better the needs of his peer. And in social congruence, there is an opportunity for peer modeling as a part of its hidden curriculum. Peer-assisted learning can improve both social skills like empathy and communication skills, and the clinical skills like problem solving, communication, critical thinking, leadership, and the teamwork skills. Kate and Durning described the 12 reasons to move from theory to practice in peer-assisted learning, like alleviating the faculty teaching burden, providing role models for junior students, enhancing intrinsic motivation, preparing physicians for their future role as educators, offer education to students on their cognitive level, create safe and comfortable educational environment, practice the feedback, alternative method of studying, modify academic medical culture, and incorporating education as a core task. Sustain medical training programs in resource-constrained setting, train leadership steps, skills, and confidence, and lastly, offer supervision responsibility in postgraduate competency-based programs. What about the hidden curriculum for from peer-assisted learning? 5 main themes were identified related to the hidden curriculum of peer teaching, like learning what it means to be a professional, learning how to learn, learning about self-care and the care of others, learning how to navigate career pathways in medicine, and lastly, learning how to be a future teacher. All these themes are important for our medical profession. So what are the challenges of peer-assisted learning? Some challenges were experienced in peer-assisted learning, like first, the student will still concerned that peer teachers may not reflect the knowledge of an experienced expert in the field. He knows that his peer not know well the information and he wants another expert in the field. This is the first challenge. Another challenge, in the less formal teaching environment, the peer teacher may not control or may have the difficulty to control the environment or teaching environment because the student take it less seriously, and this is another challenge. If the student who become tutors have learning style that are very different from other students with different levels of knowledge, so they may perceive these students as competitors, and this may cause problems. It is difficult to carry out peer-assisted learning without the support of training. So, as we mentioned before, we should train our tutor. We should train our student before coming tutors, and this may cause a challenge or problem, especially in constrained areas, resource-constrained areas. The last challenge is limited examples of interprofessional peer-assisted learning activities, and we know, and we should consider interprofessional education and its importance to prepare our students for complex healthcare system, and so we need more studies to apply interprofessional peer-assisted learning activities. Take-home message: Peer-assisted learning is important for professional identity and should be considered nowadays medical schools. Preparation and training should be considered before the implementation of peer-assisted learning. The implementation of peer-assisted learning activities in interprofessional education should be considered. And lastly, the evaluation of peer-assisted learning should be done for more improvement. After the apply, we should give our student questionnaires and focus group discussion to know the weakness and strength points to improve the process. Thank you. I finished my talk. Thank you.
The next presentation, it will be for the Professor Tamer Al-Halifi. The presentation is teaching and learning in medical education, how theory can inform practice, observations from Iraq.
The next presenter is Dr. Thamer Al-Halifi or Al-Halifi من العراق from the University of مدينة العلم. He is a professor of public health and profession education. He is also a representative of tuberculosis society in Iraq. Please, we will with the presentation of Dr. Thamer.
Good morning and good day to everybody. Good morning, Mr. and Mrs. Chairman and rapporteurs of the session. My name is Professor Thamer Al-Halifi. I'm professor in public health and medical education. And I work in one of the Iraqi medical colleges in Baghdad city. My presentation will be about teaching and learning in medical education, how theory can inform practice, and including observations from Iraq. The presentation outline will be focused mainly on, to start with, introduction to effective medical education, and then we move to implication of the educational theory approaches for the practice of medical education. From there, we have a snapshot on observations from Iraq in that endeavor, and then a presentation, final tips and takeaways. There is no conflict of interest to declare in this for this presentation. Now, introduction. Regarding the medical education and for any effective medical education, we have, in fact, 3 interrelated fundamental components. It should be available so that we can move on with the process of medical education toward advancing to competency-based learning. Those requirements are mainly a curriculum fit for the existing and the new challenges in the country and the region. The second one is high-trained academic staff able to deliver such curriculum. And the third one is the modern infrastructures and settings that are appropriate for delivering the curriculum and preparing doctors fitting for the purpose. And of course, for having these 3 requirements, there are huge amounts of resources in the above 3 components toward advancing toward competency-based learning, which is our goal. So the teachers and experts, in order to address learning needs and understand the variations in learning and approaches and how to apply them in different settings, that should be ensured. Also, education reform became a priority in many countries. And that's why curriculum analysis of current medical and health professional colleges is an important step in identifying the gaps and challenges. And no need to say that great efforts in designing a new curriculum, responding to the health needs and priorities, and ensuring graduating students with the necessary competencies and skills. So this is an introduction to how we need effective medical education and what are the requirements that should be available. Okay, let us go through a snapshot about what are the main theoretical approaches that are commonly used for regarding the education theories. Those, I mean, there are many, of course, but let us focus again in a snapshot about the 8 main theoretical approaches in that regard. We have the adult learning principles, we have the social cognitive theories, we have the reflective practice and transformative learning. We have the self-directed learning, followed by experiential learning, situated learning, and learning in communities of practice. So let us have a snapshot on each of these 8 theoretical approaches. For the adult learning process, the implications for educational practices really to have an effective learning climate established through the adult learning process, we need to be involved in a mutual planning of the methods and curricular directions. To ensure collaboration occurs in the content and learning process, and to promote self-assessment, reflection, and integration of learning. Now, what are the 3 theoretical framework for the categories of this adult learning? It's about 3 categories. The first one based on the adult learning characteristics. The second one emphasizes the adult's life situation. And the third one focuses on the changes in consciousness. And in order to move with that, we should ensure the cultivation of the intellect, the individual self-actualization, personal and social improvement, social transformation, and organizational effectiveness. So this is just in a glimpse the purpose of adult learning practice. Now we move to the social cognitive theory, and formerly it was mentioned as social learning theory. In this, we have 2 main approaches to understand learning in the social cognitive theory. The behavioral approach that emphasizes on the influence of the environment in our actions, and the cognitive approach that emphasizes on the importance of cognition in mediating our learning and functioning. Moving toward the third approach, that is the reflective practices. And in this theory, we propose that theory and the practice inform each other, and that knowledge embedded in practice, the practitioners are positioned to test and revise theories through practice, by reflection and action. So the reflective process serves as the bridge in the theory-practice relationship. While the moving toward the transformative, reflective practices, we see that the transformation, in transformation theory, there are stages of changes of transformative learning, which means that we start with initial learning development, and that is through the freedom to practice, to participate, to comfort, and learner decision-making. And then the learner critical self-reflection, which would be applied through questioning assumptions, consciousness raising, and challenging assumptions. Also, the third point, that is transformative learning through the revision of assumptions, educator support, learning network, and actions. ending with increased empowerment, and that is through the critical self-reflection, transformative learning, and autonomy. So this is in a snapshot the transformative learning, what are the steps and how can we grow through it. Then we come to the self-directed learning theory. And this is also very essential in the maintenance of professional competencies. Now, there are really 800 traits associated with the direction of self-directed learning, but they are clustered in 4 dimensions. That is the self-directness, including personal autonomy, and then the self-management in learning, and the learner control of instruction, and the independent pursuit of learning. So self-directed learning, it is essential in the development and maintenance in the professional competence. And they are responsible for professional education. They are challenged to create curricula that ensure the development of these skills and evaluation methods needed to ascertain their achievement. Okay, what about the experiential learning theory? And sometimes it's called the Kolb's experiential learning theory. Now, in experiential learning theory, learning is best achieved in environment that considers both concrete experience and conceptual models. So the learning environment for the Kolb's 4 learning environments, they are mainly the affectively oriented, which means the feeling, symbolically oriented, thinking, perceptually oriented, watching, and behaviorally oriented, that is through doing. So this is, in brief, the 4 learning environments regarding the Kolb's experiential theory. Okay, moving to situated learning. Now, situated learning is about participation, not one-sided process. It allows a broad view of learning that relates to several other concepts of learning. And the learner here is transform their understanding, their roles and responsibilities as they participate. Now, this can be achieved through building on the advantage of situated learning. We have the opportunity to rethink our students' experience and consider all the available ways to students' learning. So we think of learners as part of our learning environment rather than a temporary adjunct to it. So this is the kind of difference in situated learning regarding the other approaches as theories. And we come to the community of practice, that is the COP. Really, there are 3 constituents of the communities of practices. That is the mutual engagement, the joint enterprise, and the shared repertoire. So here, the existence and sharing by the community of a common goal, and the use of knowledge to achieve that goal, and ensuring that the nature and the importance of relationship formed among community members. So the relationship between the community and those outside it is available, and the relationship between the work of the community and the value of the activity is maintained. This is the, again, in a snapshot, the principles of community of a practice. Okay, let us move now to observation from Iraq from the current situation, but let us start with the history a little bit. As you see, this is the historical background. I think medical standards started in Iraq from 750 BC in the obelisk of Hammurabi. And he stated in many points about points related to medical education. That is how the physician, what are the rules and responsibilities related. So there are many items related. You can see that if the physician open a tumor with an opening knife, save the eyes, he received 10 units of money, and this is all in the obelisk of Babylonian Hammurabi. And point 216, the patient if he's a freed man, he received 5 units of money. If there is a mistake, then the operating the hands of the operator or of the surgeon shall be cut off. So, you know, there are certain rules for the practices for as kind of medical education. Okay, so what is the current situation, having all these theories and having this background about the medical education and how we move on with effective medical education? In Iraq in general, we have now 36 medical schools. We have in the public more than 40, we have more than 40 public universities, and we have more than 165 private universities. But as a medical colleges, we have 36. Most of these colleges really are based on the conception of subject matter. So the subject matter is presented, but with some evolution in the method of teaching that is related to indicating the curriculum emphasis on the role of variety of illustration, the kind of simulation, how it enables the student to understand and apply the knowledge as well as facilitate the development of their clinical skills. But this is the majority, and it is almost similar to many countries in the region. Saying that, there are many colleges that are grading their curriculum and the method of teaching and the kind of really curricular analysis and regarding moving with the medical education. So you see that the curriculum in many colleges now, it is a little bit shifted more toward more collaborative approach. We have research development and diffusion approach that is moving jointly with the behavioral approach. So trying to converting the equation from outcome-based, that is most of our colleges that are they follow, toward community-based education. And we are progressing really in many pillars regarding these efforts. As an example, even the taxonomy of doing research now in the colleges, which is mainly here is quantitative rather than qualitative, but they follow now more the experimental, the epidemiological, the psychometric correlation and review and meta-analysis, more frequently in providing evidence toward what they are achieving and as an evidence for what they need to achieve. Also, the other point, and let me say the progress that is tangible now, is the recognition of the World Federation Medical Education through the visits of a team from their side. And they did relatively recently recognize the higher committee, the National Higher Committee of Accreditation in Iraq, toward accrediting the medical schools. That is the 36 medical schools. So there is a joint work now, and there is a kind of recognition in that endeavor. And this is a good point that, as a positive point, to assess the progress. Also, the adoption of the innovative approaches in the region, in the Mediterranean regions and many of the Arab countries, regarding the community-based education by many medical schools and even worldwide. And that was also a kind of incentives for the workers in medical schools in Iraq and the staff and the decision makers toward accelerating the process in that endeavor. Okay, so saying that, I mean, with the that does not mean, of course, that there are no challenges, a lot of challenges that are facing the moving ahead with the, I mean, having effective medical education toward, I mean, moving from community outcome community-based outcome toward community-based education. There are many really challenges related, and we will discuss that, and we will just pass through that. But as a final things in this presentation, I want to just to present to you the presentation final tips and takeaways message. They are, I categorize them mainly against the use of effective teaching and learning strategies. Learners interact actively with the curriculum, patient, and teachers in a complex, changing environment. Theory has the potential both to inform practice and to be informed by it. The entire context of learning is important rather than any single variable, and include interactions of all variables. Values, attitude, and without explicit teaching or awareness of learning. In medical education, the relation between theory and the practice is paramount in shaping the development of competent and compassionate healthcare professionals. And theory provides the foundational knowledge and the principles that underpin effective teaching and learning strategies. Also, by integrating educational theories, such cognitive learning theories, adult learning principles, and instructional design models into the design and implementation of medical education will lead to educators can enhance the quality of instruction, promote a deeper understanding of complex medical concepts, and improve the overall learning experience for students. Ending with preparing students to become skilled, reflective practitioners capable of delivering high-quality patient care. For medical education in Iraq, we need to focus on the need for change. So evaluating the effectiveness of these changes and the management process is vital to any future progress. I want to end my presentation saying that medical education is just like diving in every ocean. Thank you very much for your kind listening.
شكرا للدكتور ثامر الحلفي من العراق الشقيق. ننتقل إلى the next speaker and the last presentation for this session. The next speaker is Inji Abu Zaid. Inji Abu Zaid is Associate Professor of Medical Education at Qanat Suez University. He will present us she will present us the presentation of EBSEA framework. The SBSEA framework, the abbreviation of this framework, E is for empower, B for prepare, and S for support, engage, and assess. A strategic approach to preparing medical students for the future healthcare challenges. Now will be with our professor, Dr. Inji Abu Zaid.
Good morning, good afternoon, everyone, according to your time zone. It's my honor today to present at the third international conference of College of Medicine and Health Science, Al-Arab at the University in Yemen. I'm Inji Abu Zaid, and I'm Associate Professor of Medical Education, and I'm today going to present to you the EBSA model as a strategic approach to preparing medical students for future healthcare challenges. The agenda for today will discuss some of the current problems and challenges in medical education and propose a solution and recommendation under the umbrella of EBSA model. So let's start. Medical education is facing many challenges in Egypt and worldwide. like the quality of teaching and assessment, and in the same time, you have large number of students. There is too much to do, no enough time, no enough resources, and in the same time, we are facing resistance from the faculty and the student to any change. You need to add up courses in the curriculum, and at the same time, you need to integrate these courses and integrate the curriculum. The faculty also are facing challenges like they need to balance their professional and personal role, and in the same time engage into continuous professional development and faculty development. Yeah, and in the same time, we are losing talented faculty members to other institutions with the rise of the labor market needs. Finally, the COVID-19 has caused a disruption of the medical education and the healthcare delivery, and there is a fear of upcoming pandemics. So how can we prepare our students for these future health, for challenges of future healthcare? I'm presenting these solutions in the form of EPSA model, which divided into empower, prepare, engage, support, and assess. Let's take each one aside. So let's start with empower. Empower is about the student to move from the didactic teaching and help the student to use logic, to ask questions, to integrate in abstract thinking, and to tackle complex issues. In another way, to move away from the spoon feeding and to help students to be actively engaged in their learning, to use constructivism and build their own meaning of knowledge, which will help them to engage into a deeper learner. Deep learning and self-directed learner are not spoon-fed. They ask questions. They know what they know and what they don't know. They think about their own thinking. Even more to empower the student to be a change agent, which means to actively contribute in the educational program so we can sail the boat together. So we recommend here, this is my first recommendation, is to empower medical students. And by integrating adult learning principles, use active learning strategies, use constructivism and co-creation process. The second point is to prepare. The traditional setting of a student sitting in a classroom is just encouraging surface learning. However, acquiring or introducing a concept like experiential learning that can be an umbrella for all the competency development. And remember, competency include knowledge, skills, and attitude. In terms of knowledge, the students are facing large volume of information that is presented in no particular order. And in the same time, the health profession educator wish to develop the learner's skills to higher levels of Bloom's taxonomy. How can we do this? Actually, we can. We can through chunking and integration. The chunking means to reorganize the knowledge again in order to manage the load that the students are processing on their short-term memories, which will help them to store the knowledge and retrieve the knowledge. And then to integrate, to create links between these chunks, which will help the student to understand the meaning, develop their own schemas, and improve their clinical reasoning, which is a fundamental component of health profession education and practice. And it has a wide spectrum from the novice to the expert. However, it's important not to see this and add up to the curriculum, however, to look at the areas that we can realign in the curriculum in order to facilitate teaching and learning of this important area. Regarding the skills, we have the psychomotor skills, which are usually taught by various methods like simulated patient, mannequins, videos, simulation and virtual reality, and now artificial intelligence. However, if resources are not available, the procedural skill lab are valuable in that regard. It offers a safe environment in which students can practice, can receive immediate feedback, and improve their proficiency and confidence before seeing an actual patient. Another form of the skills is the communication skills, which is a predominant method for teaching communication skills is the use of simulated patient and voluntary outpatients. However, it's important now to prepare our students for the new type of patient, which is dealing with Dr. Google and Dr. ChatGPT. With internet available for everyone now, people are seeking medical advice through Google and ChatGPT, which created a new type of patient called the e-patient, and we need to prepare the student to communicate with this patient. Professional values and behavior also are intrinsic to all medical practice, yet remain one of the most difficult subjects to be integrated into the curriculum. And the use of situated learning alone is not enough. We need to use role model, authentic learning that can range from structured small group tutorial to the dynamic clinical setting in advanced stages. Use multiple assessment tools, and most important, to encourage the reflective practice and empathy in the curriculum. And we can do all these preparations through multiple approaches like the integrative curriculum, spiral curriculum, or adaptive curriculum, and we're using various strategies like the problem-based learning, competency-based medical education, case-based, team-based, or peer-assisted learning. And in 2017, the Egyptian Education Authority have mandated all the medical schools to shift towards integrative competency-based curriculum. So our recommendation here is to promote an authentic curriculum, to explore the proficiency, the technology proficiency, use various educational approaches and strategies, realign the curriculum realign the clinical reasoning in the curriculum, and integrate a comprehensive set of skills. Then here it comes to the engage. Engagement can happen on campus and outside campus. Outside through the community involvement. While it's challenging to be competency-based, and few medical schools are competency-based medical schools worldwide, all medical schools should be community-oriented medical education, which means to tailor their curriculum to meet the specific needs, interests, challenges of their local community. In another term, to be socially accountable. To engage with other professions through IIPE, which is interprofession education. That means to learn from, with, and about other professions. Also to engage with patients, which can be a valuable resource as a teacher to the students. Finally, to engage globally with the global trends. So, for example, a pandemic and COVID-19 has caused disruption in the health service delivery, which justifies the need for disaster preparation in medical education and medical student training. The GMC document, Tomorrow's Doctor, encouraging the student to critically evaluate evidence and use research skills, which validate the use of scholarship in undergraduate medical education. One of the most prominent milestones in the modern medicine is evidence-based medicine, which is well recognized for its contribution in high-quality, individualized, and cost-effective care for patients. And finally, to overlook on all the educational content and the process through accreditation, which will help us to maintain quality and standards and high quality of medical education. So we recommend in engagement to engage students on campus and outside campus through community involvement, social accountability, interprofessional education, and to oversight the educational content through accreditation, incorporate evidence-based medicine and scholarship, and adopt the graduate program to align with the new job market needs like the medical engineering and the entrepreneurship in medical education. Student and the faculty. Faculty is the most important asset to any higher education institution. However, they are facing many challenges and pressure to do multiple roles. So it's important to provide them with faculty development program that should be hands-on, flexible, and frequent in order to cope with their needs and their busy schedule. Mentorship can provide support to the mentor and the mentee as well. And the main goal of the mentorship is to help the student to achieve their goals and to maintain the student well-being. Medical education is challenging, and there is high incidence of burnout, depression, and even suicide attempts. among medical students. So it's important to raise the awareness towards these challenges and help the student to overcome them by helping them to acquire self-regulated learning, emotional intelligence, and transferable skills like leadership and technological skills. So we recommend here to support students and faculty through mentorship and faculty development program to prioritize student well-being and use various strategies that are flexible and inclusive, and to help provide the students with transferable skills. Finally is to assess. Assessment drives learning. But which type of assessment? Assessment that is authentic, that is resemble to the real life that they are going to work in. That is programmatic, which means that information about the student is collected, analyzed, and immediate feedback are given to the student. That is longitudinal, which means assessment should start at the start of the course in planning and implementation of the assessment, and the decision is depend on multiple attempts, multiple assessor, and multiple tools. With the move toward competency-based, this raises the awareness for workplace-based assessment tools, which are multiple tools that aim to provide the student with feedback after observing their performance. And one of the important workplace tool is the portfolio, which helps the student to appreciate the previous experience, to reflect on the current experience, and plan for the future. And all these changes raise the need for a license exam, which will maintain the standards of the graduates and maintain the confidence of the public in our graduates. And New Horizon have revealed with the merge of technology and assessment, which will help in development of new assessment tools that can provide individualized assessment and immediate feedback. So our recommendation is to incorporate assessment is authentic, programmatic, longitudinal, focus on competencies, and use feedback and workplace assessment tool for effective learning. So finally, as the wind of a change is requiring a symphony of adaptation in every corner of medical education, it's not just about equipping our students for the challenges, it's about fostering a culture of continuous learning and resilience where each individual is contributing in the advancing of healthcare and medical education. And this is my references, and I hope you have enjoyed my talk, and I'm happy to receive any question. Thank you.
شكرا جزيلا للأخوة المتحدثين في هذه الجلسة، وننتقل إلى الجلسة القادمة بإذن الله. وقبل أن ننتقل للجلسة الأخيرة في هذا اليوم، نحب أن أول شيء أنا أخطأت في تقديم السي في حق الدكتورة دينا محمد نجيب، لأنها مش موجودة شوي في ديس أرينجمنت عندنا. احنا شوي نحفظ للأخوة الذين عدوا والذين جهودهم إن شاء الله، فهي نعتذر للدكتورة دينا أول، وننتقل إلى الجلسة الأخيرة من هذا اليوم مع الدكتور أحمد باذيب.
دكتور جميل عبد الرحمن، دكتور صالح باشعاوي، تفضلوا. مهندس احمد، are you ready with the English? موجود؟ جميل. طيب. هو بيقدم دلوقتي.
Swift. Never know. How the lace.
طيب بسم الله الرحمن الرحيم. Now we have to reach to the last session for today. We have very interesting topics. I hope that all stay with us. Now we have in the moderation Dr. Jamil Abdul Rahim, who's Assistant Professor of Community Medicine at the University. And we have also Dr. Salih Bashaoud, who is Associate Professor of Ophthalmology in Hadramaut University. Online we have Professor Jamil Ghazali. He is figure in hematology. He is Professor of Hematology at Sana'a University. And also Professor Amatul Khalid Imras. She is Professor of Gynecology in Jami'a University. We have also Dr. Jamal Hazmi. He is the Dean of Faculty of Medicine at University. We'll start with the first presentation. Dr. Jamil will present Dr. Evelyn.
Dr. Evelyn. Dr. Evelyn is the first presenter in the last session now. ما أشوف تمام. ما في إضاءة. ما في إضاءة. لا ما في إضاءة تمام. ما في إضاءة. Professor Evelyn is having a BSN from the medical education, and also he is PhD candidate in James Works University, Australia. He is the first presentation in this last session. The presentation is the training multi-transnational experience for the role playing, and this is, we are waiting now for the first presentation.
Welcome everyone for joining me in this presentation today. So the presentation will be focused on looking at training multinational SPs for role playing. I like this quote that says, diversity is not about how we differ, but diversity is embracing one another's uniqueness. And this is very true. My name is Evelyn Folonsho. I'm a clinical skills specialist, and I coordinate the simulated patient program at UAE University. I work with multinational SPs, and I've been doing this for the past 7 years. So my presentation today will sprout from my experience, and I will be basing some of the facts on the standard of best practice for training simulated patient according to ASPE. So these are the outline for my presentation today. We'll be looking at the objectives of this presentation. considering how to train simulated patients, especially focusing on the fact that they are from a diverse background. We're looking at the challenges. I'll use some of the experiences from my team to talk about the challenges, and then we look at the considerations and conclusion. I will be concluding by just highlighting some of the facts that we will discuss in this presentation. Simulation-based education has enhanced student learning in various ways. It's evidence-based that students have been provided that environment where they can practice and severally making their mistakes without endangering any patient's life. And incorporating simulated patients into simulation-based education has significantly enhanced student learning. It has helped them in their communication skills, their building confidence, and working with patients with different backgrounds. Objective of this presentation is to look at the cultural viewpoints. They are silent points, but I'll be mentioning them as I keep talking about training the SBs. The respect of diversities in culture while training simulated patients. I'll also be highlighting the recommendation steps according to ASPE, that is the Association of Simulated Patient Educator, view of how to train patients in the best way. And then I will discuss the benefits to learners' outcome. Simulated patients are also called standardized patients. Simulated patients because they mimic patients' role, and standardized because they are being kind of trained to be able to repeat the same performance over and over again for each individual student for objectivity. And so this is why they are being called standardized patient or simulated patients in different quarters. Simulated patients' role in medical education is diverse. It's every day they become more and more popular, and they are involved in more tasks than just playing the role of a patient. Simulated patients also participate in formative and summative assessment of the student, and they have to do most of their role together simultaneously. While they are role playing, they are also observing the student performance, their behaviors, verbal and non-verbal cues, and they are getting prepared to also provide feedback or debrief students after the encounter without missing their own role that they are playing as a patient. It is very tasking, but these are some of the roles that simulated patients play in simulation-based education. Culture is a crucial part to look at when we're talking about providing feedback to learners or for SPs to role play in a more realistic way. The culture of individual SPs might be in the way of their performance, but we also agree that a well-trained simulated patient can play any role of any cultural background, and they can also be able to remove that bias and that stereotype to be able to provide the learner the adequate information, character, or feedback that is due to individual students. And so the issue of cultural perspective in simulation is a vital issue to consider. These are evidences of case studies to prove that cultural exchanges can help to improve students' competency, and it helps to improve how students think and how they can manage patients from different cultural backgrounds. The objective of training simulated patients is to meet the educational goal for the learners. and to build the confidence in the SP themselves so that they can role play with confidence, to help them to portray in a more natural way, so that it can help to develop a natural response from the students, and to help in interaction, how they interact, what they should say, and what they shouldn't say. So training them help to kind of adjust the volume of responses of the simulated patient to student at each particular time, and to improve the capacity of the SPs to be able to observe the actions of the students, and to be able to prepare them for the reflective feedback they are going to provide for the students after the encounter. Requirements for training simulated patients starts from having a well-trained SP educator that has the experience of how to train SP. You can get all information on how to train SP from the ASP website. They have all good information on how to train SP, but the SP educator needs to be trained so that he can give a good training to the SP. Reading the scenario out only for the SPs to memorize will not enhance realism or natural performance of the SP. Scenarios should be designed in such a way that it reflects all culture. There should be adequate information provided for the SP before the training time. It is always suitable or better to provide the scenarios for the SPs way ahead of time of the event, and to let them know all the logistics with the session. Training the SP usually in a group happens few hours before the implementation of the role play, but it is always good to individualize the training of SP, especially when you have multinational SPs with different insight, different understanding of scenario, and different ways of communicating. You might want to approach each SP individually to role play one after the other, and then you can use that to standardize the performance of all the SP so that we can have a uniform performance when they are having the encounter with the learner. It is good to lessen surprises for the SP. Surprises in such a way that they need to improvise. They need to make up responses that are not written in the scenario. And that can be very tasking for the SP. Some SP cannot improvise responses to students that is adequate for the scenario. It might totally change the whole course of the scenario. So it is very good that we consider that. Checklist for either debriefing or feedback must be prepared in such a way that it's easier for the SP to walk through. The rolling plan must be planned every time we're having an encounter. The SP is going to have an encounter with the student. We must plan, how do they de-roll? How are they going to get out of roll? How are they going to relax? So all this needs to be in plan before the SP have an encounter with the student. According to standard of best practice for training simulated patient, number one of the domain to consider in training simulated patient is safe work environment. We care about their psychological and their physical safety. It's good to inform them about the environment they are going to work in, what they are going to be exposed to, maybe the cameras, and maybe some other substances that you use for moulage and all that. The SP needs to be aware, and they should have the right to opt out at any point. Usually, before the implementation of this role, they should be able to say they are not willing to continue, and they should be free to discontinue their participation without punishing them for pulling out of the role at this particular time. When you are working with patients, especially from different backgrounds. As an SP trainer, it is always very important to watch and to be intelligent regarding what they call a disrespect. So modesty, how much part of their body you want to expose, they need to know. What clothes you want them to wear. Even in painting, when you are doing moulage to enhance the simulation, you need to probably get not only the verbal consent, but the written consent from the SP before this is being done on the SP. So the limit of the touch the patient wants is very important. Some patients say, yeah, I'm ready to expose this much of my body. And another SP say, no, I can only allow examination to be done while my clothes are on. So we need to understand this so that we know what kind of patient is suitable for which role play in that situation. So according to standard of best practice, it is always appropriate to have an adequate plan ahead of the simulation activity involving simulated patients. All the equipment, the clothing, the materials for moulage, all these needs to be planned ahead of time, and clear information needs to be given to the SP before these are being carried on the rehearsal. So there are various ways or techniques or methods that we can use in helping the simulated patients to up their skills and to be able to portray the role in an authentic way. Number one is that the case scenario should be built in such a way that it's easy for the SPs to know their role, to know the character, to know, to understand what volume of behavior is required for that scenario. Usually, it is good to provide the scenario to the SPs few days before the time of the encounter, and then the SPs have that opportunity to read and also to internalize, to find out how they can best play this role, and to be able to understand the content when we come together in a team for training just before the implementation. What we normally do in my team is I ask them question, a kind of a popcorn question on the scenario, just for me to be able to find out where they are struggling, what they are able to retain, or what they are struggling to be able to memorize. Sometimes I tell them, write it down. If you write it down as I'm talking, you'll probably be able to memorize. So, well, we look for methods that work for us in our team, because I have a team of multinational SPs and from different educational background also. So for role portrayal, it is always good to provide a video of that kind of a scenario to the patient, so they can watch the movement of the patient, they can watch the display of emotion of the patient, so that this enhances the way they have to play the role. And for physical examination, it's always important to provide the SPs with understanding of what part of the body is going to be exposed, how much touch they are going to receive from the learner, and maybe the sequence of the examination, if necessary. But usually what we do is we expose the SP before the encounter with the student. The SPs is exposed to this kind of examination by the facilitator of the session. So this helps the SP to know that this is exactly what the student are likely to do when they have encounter with them. So observational skill is very important. It's something that you need a patient that is very focused, and a patient that is capable to be able to observe the students while they are role playing, and to be able to provide valid feedback to the student. But I must say here that an SP needs a thorough training and experience to be able to provide feedback and to debrief the students on their performance. So they are exposed to the checklist. We play the video of a patient and let them review it with the checklist. All these are some of the practices that is agreed by the standard of best practice ASPE, and which we are also trying to imply or replicate in our team so that the SPs are well prepared for providing feedback to the students. So there are several benefits of having multinational SPs in your team. Number one, it helps the students to develop their competency. It exposes them to how to communicate with patients from diverse cultural background. It helps to develop a kind of realistic scenario, and it helps the student to deal with bias and stereotypes. Challenges. There are several challenges which cannot be enumerated here that you face when you are working with a pool of multinational SPs. But the very key challenge sometimes is language and understanding, perception. How do they perceive this role? How do they understand this role? These are the challenges. But all these challenges are, we can consider training the patient adequately. That is the way to deal with the challenge. A well-trained simulated patient can perform any role adequately. So we consider training them adequately, and assessment of the feedback logistics. If you want an SP to provide feedback to the students, then the feedback logistics and training and the checklist and the timing, all this must be clear to the SP, and they must be trained, and they must be able to do a dry run before they have an encounter with the students. Finally, I would say if a patient is well trained, they can play any role, despite the fact that they are from different cultural background, or they have different accent or different foresight for life. Once they are well trained, they will be able to perform that patient role that is required so that students can learn the skills they are meant to learn. It is obvious that exposing the students to multicultural simulated patients will enhance their communication skills. We also help them to build that behavior suitable to attend to patients in real life, despite their diverse cultural background. Thank you very much for listening to me. I hope you enjoyed this presentation. Thank you.
Thank you, Dr. Evelyn, for this nice presentation. Now we move to the next presentation. Yes, we'll move to the next presentation now. Yes.
The next presentation from الإمارات الشقيقة, أحد المشاركين الإمارات الشقيقة, that's عوض العيسى. This is an instructor and lecturer in the Department of the United States Arab Emirat University, and he has a PhD from the British University in Dubai. He will speak about a good and important subject, that's giving and receiving a feedback or effective feedback in medical education. Giving and receiving effective feedback in medical education. This is a good subject. Now we will be with our Professor عوض العيسى.
بسم الله الرحمن الرحيم. السلام عليكم. Hi everyone, my name is Awad Al-Isa from Department of Medical Education in United Arab Emirates University. It's my pleasure to be with you today. I would like to thank this conference organizers for the kind invitation. My talk today will be about giving and receiving feedback, effective feedback in medical education. Considering the short allocated time, I will try to use the coming 20 minutes wisely to discuss this topic briefly. So starting with the learning objectives, at the end of this presentation, I expect the audience should be able to define feedback concept in medical education context. They should be able to identify, recognize constructive feedback, characteristics, principles, and giving methods. Identify possible challenges in giving, receiving feedback, and recognize barriers to giving effective feedback. So the number of publications related to feedback in PubMed has seen significant growth over the past years. This reflects the increasing interest in this topic across various medical fields, including medical education and also in clinical practice. So what is feedback? Feedback, if you pull out the Oxford Dictionary and you define feedback as a term, it means that modification and adjustment, and they highlight the difference between the desired and actual result as an information to be in feedback. If we get the definition for feedback from medical education literatures, feedback in medical education means a process whereby learners obtain information about their work. Their work should, what we mean by their work is the similarities and the differences between the appropriate standard for any given work and the qualities of work itself. The aim of this process is in order to generate improved work. So feedback is dealing with a behavior, and that behavior could be positive or negative. In both ways, feedback, when you give feedback, you describe the behavior, whether it's positive or negative, and you mention the positive effect of this behavior and the negative effect of this behavior. The only difference between positive and negative behavior in the management, where you aim in giving feedback, is to utilize the positive behavior in the future, and the negative behavior you would like to avoid it in the coming future. This leads us to the differentiate between feedback and praise and criticism. It's very clear that praise and criticism are extremely different than feedback, because praise and criticism, they are more about generalization. You can praise someone by saying, good job, thank you, while in feedback, you need to describe the behavior and choose the particular behavior, describe it, and give, study it, and give the plan to improve or sustain this behavior. Also, praise and criticism is about judgment, which is coming from experience, while in feedback is about motivation, how to motivate the learners. In praise and criticism is promoting defensiveness by the learners, while in feedback it promotes self-reflection. Praise and criticism deal with the past, while feedback is about future. You are using the information from the past to improve the future. And praise and criticism is stating a problem, while the feedback is providing solutions to make it better. Praise and criticism can be, or sometimes is given in public, while in feedback is always should be in private. So why we are giving feedback in medical education? Feedback is very important because it is like a channel of communication between the learner and the trainer. And also, this will help that learner to get insights about their actions, the effect of their actions, either about their performance or over the patients. Also help them to set up their goals, and it improves learning performance, learners' performance. And also feedback is, it's the link between assessment and learning, for assessment for learning. It has been found that also feedback is driving achievement, and this will all support actually the trainer-based medical education to be moved to the learner-based medical education. So how we are giving effective feedback? To give effective feedback, we must answer the three major questions. The first question is, where am I going? So what are the goals? And this is actually called feed up. And the next question is, how am I going? What progress is being made toward the goal? And this is how you look for feedback. And the third question, which is very important, is where to go next. So you have to identify the activities that you need to be undertaken to achieve a better progress. And this is what we call it as feed forward. Out of these questions, if you look to feedback components, the first component should be observation of the performance. So the instructor or the trainer should look for with a critical eye for the skills and that needs to be improved, identify it, and look for the opportunities of improvement. The second point is to evaluation of the performance based on an accurate assessment which should be set previously. The third step is the guidance to the next level of performance, and this through describing the next level of performance relating to the current level, and also based on the educational goals. And the fourth point is about the resources. You have to facilitate the improvement process itself by maintaining the presence of the resources and the learning activities to meet the timeline and to achieve the learning level which you aim to. So how to do or give constructive feedback? When we mention the function of the trainer, the critical eye of the trainer should be able to do two functions. The first one is to listen and assess learning tasks. This could be the learning task could be case presentation or interpretation of the data, management plan, whatever. He should be able to listen and assess. In the same time, he should be able to quickly identify the needs and the misconceptions. And this should be done simultaneously in a way that allow the instructors to identify all these needs. If you look to the models of giving feedback, there are many models in literatures for giving feedback. I tried here not to explain all for the time's sake. I will not explain the models, but I can summarize the steps which mostly all models they are following. So if you are going to give constructive feedback, you should start always by learner's self-assessment, which is looking to what went well and what could be improved. You have to ask the learners and he should assess himself for this. And why this is important? This is important because when you ask the students about these things, to think about their work before receiving feedback, they say that it scratched up the soil in their brain. So the feedback seeds have a place to settle and and also to grow. The second step is to reinforce. Start by always validating the well points which have been done, the positive points, and to improve, to reinforce it. And then the third level is select specific areas for improvement. Few points. You have to focus on maximum 3 points. Start by agreement, review the points, understanding. Better if you could ask the learners by himself, he can correct them. And also how to be done in an appropriate way in brief. The first step is to summarize areas, strength of improvement. You have to summarize these strengths and improvements, and then formulate specific, realistic plan with clear, directed goals. This is the aim of this is the steps of the constructive feedback. Then you have to start again. The same process which we did now. And over all these steps as an instructor, you should be using the two functions which are listen, assess the learning task, and quickly identify the needs and the misconceptions. All these sessions should not take more than 5 to 7 minutes. Otherwise, it will be a lecture. So 5 to 7 minutes is a suitable time for giving feedback. Now, moving to when to give feedback. If we'd like to give feedback, feedback is a dish best served warm. It's all about the timing and place. It's better to give feedback immediately after any encounter. So, because feedback about motivation, so you have to use the time. You can give feedback during lectures, question and answer after written examination, performance assessment, workplace assessment, OSCE, Minisix, whatever, residence rotations, ward rounds, follow-up any interaction with patients or colleagues, follow any daily activity. Anytime you can choose the feedback to give a feedback. But what are the characteristics of a constructive feedback? The good feedback and constructive feedback should, first you should choose a appropriate setting to give the feedback. It should be in the right place, it should be in the right time, and you should choose a right context to give the feedback. Should be also labeled, and when we mean by labeled, you should say that this is a feedback session. I'm giving you a feedback for the learners. It should be collaborative with open-ended questions, so you can allow the learners to explain and answer. It should be clear and neutral. It should not be judgmental. You should not use judgmental language. It should focus on the performance, not the individual. It should be specific, descriptive, describe the whole behavior. You should highlight and suggest improvement areas. It should be ongoing and frequent, planned. It should be direct observations, based on direct observation, and it should emphasize positive active aspects of the behavior. It should be based on learner levels also. You should consider the learner levels. Now, the types of feedback, there are many types of feedback, but if you look for feedback as if it's formal or informal, the formal feedback is usually planned, structured, and scheduled feedback. It's usually conducted in the mid of the rotation or the mid-course, and this usually to help the learners in optimizing their learning in the remaining parts of their course. And it could be informal feedback, and usually this is short, immediate, focused feedback. Usually it takes place when immediately after any educational activity. Also, feedback could be formative or summative. And when we say that formative, it means that it's continuous, ongoing feedback that is given frequently during learning to facilitate and improve the learning while it's happening. While summative feedback, it's usually happened at the end of the rotation or the end of educational event or a major step. And usually it focuses about the performance concept and the pattern if it's structured and planned. Now, there's a big misconception in feedback as a conflict based on interests, because as we know, feedback is between the trainer and the trainee. So because actually the trainer interest is usually meet the required performance level. So his role is usually to identify the areas that need improvement, while on the other side, the trainee interest is to meet his required performance level, which is actually he's required to ignore this need, the need of improvement, because he would like to have finish the performance level. So this guides us to discussing the challenge when receiving feedback. The challenge is usually receiving feedback between the learning and versus. First challenge is called the learning versus acceptance challenge, which is that usually the learner will say to himself that they are giving me feedback because they don't like me or they don't accept me. While the trainer should be able to change this mentality of the learners, that to tell him that, or he should understand that we like you enough to take time out of our time day to help you and to improve and give you this feedback. So then the learner will accept feedback as an opportunity of improvement. And the other challenge is the imposter syndrome. You know that the learner, usually they look to themselves when they got feedback that they start to doubt their worth, and that they know nothing on the part which you are giving a feedback about them. While they should understand in reality that they know something, and there's nobody who knows everything. You always know part of something. Everybody know part of something. So now here the role of the feedback giver is to support and encourage the students, and also to get strategies for improvement. And he should be able to provide always opportunity for the learners to provide reflection. So there's some mistakes when giving feedback. It's happened by the trainers. They are giving, when they give feedback, that they are bringing up previous mistakes. This is wrong. Actually, you should not bring previous mistakes. You should discuss the behavior, particularly unless that you think that this mistake actually is threatening the patient's life, or you think that this happened many times. Also, you should not focus on personal issues, such personality. It should be about behavior. It should having an audience, as we mentioned earlier, keep the feedback as private as possible. Overloading the trainee, especially if it's negative. Overloading the trainee also, as we mentioned earlier, just select three parts to focus on and feedback. Don't give feedback when you are angry, or when the learner is angry also. And try to avoid giving feedback following a serious adverse event, like when the learner is busy in documentation or doing a task which is related to the case. The barriers to give effective feedback, which usually happen, that the trainer usually is always have that fear of upsetting the trainee, so he try all the time to give positive feedback, and sometimes he will miss some the areas of improvement that needs to be discussed with the learner. Also choose the wrong time, place, and privacy. Self-justifying of negative feedback and disregarding future feedback. Sometimes their feedback is giving too generalized, and also not to give guidance as to how correct improve behavior. This is wrong. You need to have a remediation plan all the time, and you should be ready as a feedback giver to provide solutions, or at least help in putting a plan for solutions. Gender and age and educational culture differences sometimes form a barrier in giving and receiving feedback. It should be always considered. Time, lack of time also is a barrier, but you have to find time, and that's why feedback should be embedded in the plan of the curriculum, in designing the curriculum as part of the course in both delivery and assessment. Lack of feedback experience from both the learner and the trainer is another issue, and this will always make both parties uncertain about the value of the feedback. Sometimes also over the confidence or lack of confidence from both parties. Why learners, they don't ask for feedback? They don't ask for feedback. Maybe they don't know how or who and when to ask about feedback. Sometimes they are not certain about the value of the feedback. They are unsure about the purpose of feedback. They worry that the feedback will be negative, and we usually all these linked to previous bad experience with feedback. They believe that feedback will be always personal. Their past experience with the feedback was not helpful for whole, and sometimes there's inconsistent feedback from various sources, different facilitators or different instructors. They are giving different feedback with different ways. So there's a major issue also, which is about the trust. When there's a breakdown of trust between the feedback provider and the recipient, this will be a major issue, because when they provide two generalized feedbacks provided that did not relate to the specific facts or observation, and sometimes also the feedback that does not give guidance as how to correct or improve behavior. This all will make the trainee becoming impervious and self-justifying to negative feedback and disregarding future feedback. To overcome all these challenges in giving feedback, the feedback should set clear criteria for desirable performance, transparent evaluation process, explain when and how to whom a faculty is evaluating the feedback, conduct direct observations, provide them with the opportunity to self-reflect, investigate, and help them resolve any factors that may be affecting their performance. And also could conduct always a follow-up meeting to help and support. And you should have many plans for this. To summarize my talk in giving feedback, you should label the feedback, establish dialogue, create shared goals, share the constructive details, and ask for understanding and develop an action plan. And for those who receive the feedback, they should recognize the feedback, be active and participant, create shared goals, ask questions, avoid the defensive, identify and avoid triggers, and develop an action plan. My take-home message today: the learning environment should foster feedback. Effective feedback has the potential to improve the skills and change the behavior of the learners. Using the structured format to provide feedback will always assist in self-reflection and provision of clear constructive advice. The curriculum always should be designed to inspire students to engage in feedback. Thank you so much. I run fast, but thank you so much for the audience. I hope you enjoyed the presentation. If you have any queries, please don't hesitate to contact me. This is my email here, and thank you so much, and good night. I hope you will enjoy the rest of the conference. Thank you.
Thank you. Thank you, Dr. Aoud Isa, for this topic about the feedback.
The next presentation, which I think is the last for this session, yes, will be presented by Muhammad Al-Hassan Abdullah Sayyid, and he's an associate professor of medical education, the School of Medicine at University of Limerick at Ireland, in Ireland. Ireland, yes, University of Limerick at in Ireland. The topic which will be presented by him, the variations on theme navigating social accountability in medical education.
الرحيم. السلام عليكم جميعا. It is my pleasure to be with you today, talking about social accountability in medical education. And for this, I would like to thank the organizing committee for inviting me for this esteemed meeting. And I hope all the success in the meeting for all people, and that we can continue this collaboration in our region for the development of medical education. So in this presentation, I'm going to speak about a few things, which are what is social accountability in medical education, and we are going to have hints about the multifaceted landscape of social accountability, and I'm going to mention this in a minute. And I will discuss some of the paths that taken by different medical schools to be socially accountable. And definitely there are factors that can affect the implementation of social accountability. And at the end, I'm going to go through some of the case studies for medical schools who implemented social accountability. Hopefully this will encourage other medical schools to go in this pathway. To start with, social accountability definition, it is defined in 1995 by the WHO as the obligation of medical schools to direct their education, research, and service activities towards addressing the private health concerns of the community, region, or the mandate or the nation that they serve. Maybe someone can say, so what is new in this? The new thing is that now it's an obligation, and of course the WHO will ask for this serving the community to be a mandatory thing. And the social accountability has included the service and research besides education, because previously most of the medical schools, they tend to use community-based education or community-oriented medical education, so they can address the society needs. But the social accountability, it obligates medical schools to include the research and service. This is number one. And then the most important thing in social accountability is that we need to address the private health concerns. And when we speak about the private health concerns, that means we need to have a discussion with all stakeholders, including the communities themselves, in order to define those priorities, because the priorities that can be set by the medical school may differ than the priorities that are perceived by the community or by other stakeholders or by the health system. So we need to have like a collaborative discussion in order to identify those priorities, and then medical schools can change its programs, can change its research direction, can change its way of serving the population in order to address those private health concerns. So to make this a reality, the social accountability has identified 4 values for education, research, and service. Those 4 values are the relevance, where all the activities should be relevant to the need of society, with high quality, and with cost effectiveness, and with equity. So in all the 3 activities, which are education, research, and service, we need, when we plan them, when we are implementing them, or when we measure the impact, to measure them against those values. Are we addressing the relevant things in the society? Are we doing it with the highest quality possible? And this quality means accessibility is one of the indicators for quality, because sometimes we can provide something that is not accessible by the community, and in that way it will not be usable by the society. And with appropriate cost effectiveness, so we will not overload the community, we will not overload the health system, we will not overload any partner, and with equity, so all people have access to all services, whether they are the education, the research, and the service. Those 4 values are very important because they will be the core against which you measure your social accountability direction. So the benefits of social accountability are many, but we can summarize them in three main categories. That when we are social accountable, we help enhancing the community health, and because we are addressing the outcomes. And when we address the outcomes, that means we are working towards improving those outcomes and to the favorable side. And also, social accountability gives the students a chance for professional growth, because the aim is to develop a health care professional who are able to make a change, who are able to address the need of the society, who are able to be as change agent in the health system. And these things definitely are going to make the institute or the medical school has an impact in society and impact in the health system. So when we speak about social accountability, we speak about how can the medical school go beyond its walls to serve the society. How can we be part of the health system that is going on? How can we complement the work that that is done by other stakeholders in order to improve the community, and we will be part of that serving consortium for the society. So we need to think about beyond our walls. We need to think about beyond the boundaries that we have in our medical schools. And by doing social accountability approaches, we help in reducing health equity, and mainly maybe we can have a role in addressing the shortage in health workforce. And maybe all people, they know that there is a great shortage of health workforce all over the world, but the more shortage we have is where we have the more burden of disease. So maybe we cannot bring in a lot of health workforce, a lot of doctors, a lot of nurses, a lot of other health professionals, but maybe we can train the people that we have in a way that they can cover this shortage. So we need to innovate in order to address those problems, and this definitely needs a training that is relevant to the society, relevant to the community, and with high quality, and as I mentioned, that has the cost effectiveness and equity in mind while we are training our students. So this is in terms of what is social accountability and what are the benefits that we have. When it comes to the practice of social accountability, it is not an easy thing, and there are a lot of ways. One of the problems with social accountability is that people ask for a pathway for social accountability. Because we are speaking about different communities, we are speaking about different priorities, and we are speaking about different priorities within the same community over time, then the most important thing in social accountability is that there is no one size that fits all. You need, as a medical school or health professional institutions, to find out what are the priorities and how can you address them. And this is very, very important, because if we set like a formula or a single pathway for social accountability, then we will end up by doing things that may not fit lots of the societies. So when we come to practice, and when you see the published literature about social accountability, you will find different approaches for social accountability, and this is very important for any medical school who would like to go in this pathway, that you select the approach that fits your needs, and maybe you need to innovate in the way that fits your needs. And I'm going to mention some of the pathways that has been already implemented, so people can have an idea about what can they do. Why that? Why the implementation is different? Because we have diverse approaches. Each medical school has some influences that affect its implementation of the programs. Each medical school is in a different place that has a unique culture, unique social and economic context. So a medical school in Yemen is different than a medical school in Saudi Arabia, in United Arab Emirates, in USA, in Sudan, in Egypt. So we need to consider those factors before we adopt anything. So those are very important. And there is very important thing, it's global versus local. We tend, now we are in an era of globalization, and we tend to have an international reputation. So how can we have those global goals and we make some changes in them so they can fit the local strategies and the local context? This is important because when we speak about social accountability, we don't mean to have or to end up with a medical school that is local. No, we need to have a medical school that can act locally with a global flavor, with a global insight. So because the students themselves, they can move out when they graduate. So this balance between the global need and the local needs is very important, and it will affect the how the approach to social accountability. So as I mentioned, there is no one size fits all. So if you look into the literature, you will find different approaches to social accountability based on the community needs, on the resources availability, and the institutional goals. Each institution has a goal that was set earlier. There is a mission. But the mission usually related to human beings, related to population. There is no medical school that has a mission that is not related to the health of the society. But maybe there are some details which are different. The community needs are different, and the resources available for each medical school are different. So we need to think about that. And as I mentioned, I'm always mentioning this, we need to consider the variations. So if you see a medical school implementing an approach for social accountability and you cannot do it, that does not mean you cannot be socially accountable, but you need to consider your context. There are some influencing factors for social accountability, mainly the cultural context. As I mentioned in the beginning, for example, there are in some countries, the community-based activities cannot be implemented the same way as in other countries because of the cultural context. The resources, again, and I'm trying to stress on this, although I have mentioned that, but the resource availability, it affects the way we implement our programs. This does not mean that if we have a scarcity of resources, that means we can do nothing, but we need to be realistic and to see how can we improve in our resources. And here comes the partnership thing, because in reality you will find a lot of partners who are work towards improving the health care of the society. So if we have an institutional partnership in a way that we complement each other, this will be better than we compete each other, especially that when you have a scarcity of resources in a medical school, that means to a larger extent there is scarcity of resources for other partners. So if we work together, that will help us a lot in order to achieve our goals. And the partners could be the health system, the government, the NGOs, community organization. All those organizations can make our pool of partners whom we work together in order to be socially accountable. So by this, I'm going to mention some of the case studies in very brief, so people can have an idea about different approaches to social accountability. This university, Wollongong in Australia, they implement a curriculum that focus on rural and regional health, because this is their concern, because they have many regional areas, and the students are trained to meet the needs of the underserved communities, demonstrating successful alignment with education and society needs, because their community is mostly rural. So they train the students there. In Northern Ontario Medical School in Canada, they adopt the community engagement approach in order to have the society have a voice so they can identify their needs. So you will find in Northern there is a great involvement of the society and the community in the curriculum development, even in evaluating of the graduates, and they take all those data to inform their curriculum, inform their research, and inform the service that they provide. In Indonesia, the medical school in that university, they are again, because Indonesia has different remote places, so they prepare the graduates to work in rural and remote areas, so they can cover the shortage there, and they highlight the local context in their curriculum to a larger extent. So when the graduates, when they come out, they come with great knowledge about the context. In Ireland, we are trying to address the local health problems through the problem-based learning cases. So we like making a map about the needs, and we make sure that all the health problems are addressed in our problem-based learning cases. But again, we are very cautious about the equity and diversity principles in assessment and curriculum. For example, we reviewed all the questions in the exams in order to make sure that the questions are addressing different ethnicities. For example, the names which are used, the areas that are mentioned in the questions. For when you say X, who is like 65 years old man coming from, so all those we try as much as possible to have address all the ethnicities or all the areas when we provide the questions to the students, so they will not feel that there is a deprivation, and hiddenly the part of hidden curriculum, they can figure out that they may face different people from different problems, and we use the data from different organizations to inform our curriculum and to inform our problem-based learning cases. In Philippines, because they have a shortage and they don't want to have any dropouts, they implement the step ladder curriculum, where the curriculum can, in the first 2 years, can graduate a community health worker or a midwife. If you finish 4 years, you can graduate as a nurse, and if you finish 6 years, you can be graduated as a doctor. So by this, they cover the shortage and they don't lose anyone. In University of Jazeera in Sudan, they do implement the community-based education with a greater extent, where the curriculum has more than 25% that is implemented in the community. So there is great connection between the students and the society in their places, and they feel all the benefit of the health of the community needs and the health system. So the take-home message from this presentation is that context matters. So if you want to be socially accountable, you need to consider your context to the larger extent. And I hope this will help you imagine how can we go towards social accountability. Thank you very much, and I wish you all the success in the
Thank you, Professor Muhammad, for these interesting topics.
By this, we conclude the sessions for today, and inshallah, see you tomorrow at 8:30. We'll start sharp time, and hopefully, inshallah, we'll finish tomorrow earlier by better control of the time. Thank you.